Hello everyone, and thank you for attending my presentation here. My name is Jessica Goggin, and I'm going to be talking about program development and specifically our experience at UC San Diego. I have no conflicts or disclosures. In terms of our objectives, I'd like to review UC San Diego Health CF program growth and development trajectory, talk about some key financial terms used in healthcare, especially some misunderstood, discuss challenges and efforts to secure additional resources and where funding eventually was obtained, and then review some tips for communicating and building relationships with both hospital administrators and other decision makers, and then learning strategies to advocate for improved resourcing of pulmonary programs. Right, first I'd like to talk a little bit about some background around our UC San Diego Health Adult CF program. Our care center itself was established in pediatrics in the 1970s, and it was in the mid-1990s that we started a separate adult program. Our census currently is around 280 patients, give or take a few, depending on how we count that. And we are one of the fastest growing CF programs in the United States, and we have been so for the last several years. All right, I wanted to give some of you who may not be as familiar with CF programs and teams a bit of an idea about what makes up our multidisciplinary team. So as you can see, we have the expected components there, our physicians, medical director, program manager, and then we have NP, RN, LVN, pharmacist, dietitian, RT, social worker, admin, and research staff. So the main message here is just that this is a very comprehensive multidisciplinary team. I've worked in other programs before where we may have called ourselves multidisciplinary, but we were not as robust. So I wanted to give you an idea of what this looks like in the CF community. Next, I wanted to give you an idea of our CF patient census. Now, note this slide does span across about 15 years. In 2005, we were sitting around 50 patients or so, and you can see, significant incremental growth. Those first two marks on the bar there really span 5 years, 2010 to 15. And then you can see a continued incremental trajectory through 2019. So really, I think this is reflective of the fact that we are one of the most rapid growing programs in the country. But that just tells part of the picture. So this is a little bit of a busy slide, but I'll try to walk you through it here. Beginning in the far left-hand side, we had about 50 patients, as we talked about in 2005. I wanted to give you some relation to what that meant in terms of FTE and clinic access. So we had 4.0 FTE at that time. Clinic access was 1 day a week. You can see an incremental access or incremental increase there 5 years later to 150. And look at the difference in FTE, not very much in FTE. So 150, triple the patient population, but just a half FTE increase, so very minimal there. And then you can follow it along to 200 patients in 2015. Again, just a very incremental access in FTE. One of the other things to look at is clinic access, starting out at 1 day a week. Now we're at 1 to 2 days a week by 2015. And then the patient to FTE, this is how many patients do we have per FTE. And you can see that increased from 12.5 to 40. So you significantly increased burden on the workforce is what that indicates there. And then you can see moving along all the way to 2019 and 20, where we sit today with about 280 patients and a staff FTE of 12.5, clinic access of 3 days a week. Capacity per week for clinic is about 45 to 60 patients, so significantly increased from the 10 to 12 that we started with. And then that patient and FTE number that has now gone down to a comfortable 22, and that's about right for such a high acuity population. This is about where we need to be. Now, looking, obviously, whenever you have growth, you have a lot of challenges that grow along with that. So as our patient population grew, these are some of the challenges that we faced. One, or challenges related to just the healthcare financial environment in general, multidisciplinary billing, quality of care, and then the impact on the multidisciplinary team itself, which we'll go into in a little bit more detail. So here's a few of the challenges we face just related to the healthcare financial environment as it is. First of all, some of you may or may not know this, CF programs at best are neutral in terms of contribution to margin, and we'll define that term here in a few minutes. Our primary billable activities are clinic visits. We have minimal, if any, procedural billing. So therefore, in terms of requesting additional resource, the program relies heavily on mission. Another challenge we have in regards to healthcare finance is that not all financial professionals recognize the value of downstream revenue and don't always accept that as a valid justification for request. And again, we'll define downstream revenue as well. And then in the CF community, and I'm sure in some of your communities as well, the payer mix is a challenge. So because CF is a very expensive disease to have, medications are sometimes prohibitively expensive, as well as the disease is a progressive illness. So some people are not able to work full time either ever, or if they do, then sometimes they have to stop working full time. So our high proportion of public payers in California includes GHPP, Medi-Cal, and Medicare to be the most common. So as I said, we're going to dig into these two terms just a little bit more right now. First of all, contribution margin. Contribution margin is a term that's very often misunderstood. People think of this as profit, and this is not profit per se. It's actually a very simple calculation, even though it's misunderstood. It's the dollar difference between total net charges and the related variable expenses. And it's often expressed by percent total charges. So rarely would you hear someone say, our contribution margin is $1,000. You would hear them express that as a percentage. So just as a very quick, simple example, total net charges for a bronch of $3,200. If related variable expenses were $22, you'd have a contribution margin of 31% or $1,000 in this case. Now note, these are variable expenses. This does not yet take into account the fixed expenses. So if you were looking for profit, what you would do is then account for your fixed expenses and your contribution margin minus those fixed expenses. Now that becomes what you could consider profit. Now, downstream revenue, like I said, is variable as to whether people appreciate this as justification. But it's revenue generated across the entire continuum of care. So whereas contribution margin is a program-centric view of value, so everything's focused on the program itself, downstream revenue is a patient-centric view of value across the health system. So everything that happens to that patient, or for that patient would be a better way to put it, is considered part of the downstream revenue. So in CF, inpatient stays, outpatient radiology, pharmacy, etc. Now let's move on to challenges related to multidisciplinary billing. I'll be very frank, this continues to be a challenge for us today that we deal with on a regular basis, and I'll talk a little bit about why. So in terms of charging for multidisciplinary billing, some payers require a copay for every discipline seen during a single clinic visit, and this can result in a financial burden to patients. So you can imagine, if you recall that slide where we had all of our different disciplines, imagine having a $25, maybe even $50 copay per individual discipline that you see. That can add up really quick. And sadly, it can result in subsequent refusal of patients to see the multidisciplinary team members. And as I think many of you probably know, multidisciplinary care is essential to quality care in CF. In addition, our guidelines of care from accreditation require that each patient be seen at least annually by every discipline. So this then negatively impacts our publicly reported metrics as well. We also have some challenges related to quality care in and of itself, and that is, and this is not rocket science, as your population increases, if you keep the same number of FTE, then you're going to have increased difficulty maintaining that high quality level of care. This can lead to patient, family, and staff frustration. It also causes, and indeed in our case, caused a turn away from routine quality improvement activities. And this is mainly because our care style really transitioned from that of being proactive to one of being reactive and one of crisis management. So here's some challenges related to our multidisciplinary team or our leaders. Clinician leaders may lack experience and training in business of healthcare. I can own this one fully. I've been with the program or was with the program for 14 years. Along the way in the last 10 years, I learned a lot. But in the beginning, I was very adequately trained as a clinician, but training in healthcare finance and business was not something I had received a lot of at that point. In the last 10 years, I've certainly received my fair share. So leaders may also step in to assist clinically and thus not have time for program development and advocacy. And this is really common. We don't go into healthcare, usually to be business people. We typically go into healthcare as clinicians, and we are therefore clinicians first. So this is indeed what I did for many years as well, is step in clinically and then simply not have the same amount of time for advocacy. And of course, there's a feeling of defeat that's natural and human when repeated requests for additional resources are denied. So challenges related to the multidisciplinary team specifically. CF clinicians tend to be highly dedicated to the patients they serve. If you look at longevity, if you've been with the CF program 5 to 10 years, you're sometimes considered a newbie. People tend to get into the CF community and stay there and develop quite a strong passion for the CF community in general. So we have these dedicated staff, and they work many extra hours to provide care often. And this can lead to staff burnout. It can lead to increased moral distress when they're having to do more and more with less and less. Staff resignations. We were very fortunate in our program not to have a lot of resignations, but we did have a key physician resign from our program directly related to these issues. So do any of these challenges sound familiar? If we were in the room together, I'd be asking that we raise our hand, and I would expect that I'd see quite a number of hands go up. I'm sure many of these challenges sound familiar to you in your programs as well. So we're going to talk some about program development and how to effectively advocate and build programs. But first, I want to talk about mistakes. I think sometimes we don't talk about mistakes often enough, and there's so much to be learned from mistakes. So I want to take a little side journey here to talk about mistakes. So what mistakes did we make? And you could also say, what mistakes did I make? I phrase everything we, but I like to own the mistakes and share the successes. So 1, complaining too much and planning too little. Not speaking the same language as hospital administrators. Sometimes giving up too early, getting our no and thinking it's a rock solid no rather than thinking, okay, how else might we do this? Believing there was only one possible solution and going above and beyond for patient care. Now, I'm sure you noticed that going above and beyond was listed as a mistake, so I think it's important to ask ourselves, when does going above and beyond become a mistake? Well, first of all, if it enables an untenable situation to continue, it becomes a mistake. I can own this one fully. This is one that definitely I did. If it fixes issues in ways that lead to additional issues, disguises the situation and prevents others from seeing it clearly. So no one knows you have a problem because you fixed it, but in a way that's on perhaps your own back or well-being or that of staff. Unsustainable and contributes to burnout. So going above and beyond in and of itself is not a mistake. It's when these factors are contributing there. So obviously, I just said going above and beyond is not always a mistake, fortunately. We're in healthcare. I think there are days that going above and beyond brings great meaning and value to what we do. But it's only when we enable the situation to continue for a prolonged time, that's when it becomes a mistake. So at this point, our enabling becomes part of the problem and not the solution. So where did we eventually get additional resources? I wanted to hop into this right now. First of all, from the medical center, we were able to obtain additional resources. We were able to somewhat advocate using downstream revenue. That was still, controversial even in our own endeavors there. Our division helped in providing additional support. from a provider perspective. We had some strong interdepartmental collaboration with respiratory therapy and especially pharmacy, where we had some shared FTE and were able to shift some resources in that way too. And then we had external sources, CF Foundation grants. We had a small amount allocated through transitions of care, some 340B funding, and that came directly through the pharmacy efforts, and then some philanthropy as well. So what did we learn, or what did I learn in this process? One is that program development requires skills that can be cultivated. You're not just born to be good at it or not. It's kind of like difficult conversations. A lot of people think that we're either good or not at difficult conversations, but that's a skill that can be learned, and this is as well. So the essential skills that make up the skills required for program development are strategic mindset, relationship building, and advocacy. So first of all, in terms of strategic mindset, this is the same thinking required for program development as is required in health policy work and politics. And I want to stress that being political is not a negative quality. It's actually an essential strategy. And this is something, of course, it's political season right now, so it might be a hard sell, but just trust me, being political is not a negative quality. Being goal-oriented involves political work, just necessarily it's part of it. And a strategic mindset requires awareness of opportunities to plant seeds for future anticipated requests. So I'll give you a few examples of a non-strategic versus a strategic mindset. So a non-strategic would be complaining versus your strategic scheduling your meeting with the appropriate stakeholders and decision makers. So part of it is figuring out who those are. Submitting requests without your supporting metrics or documentation is non-strategic, where performing a needs assessment will be quite strategic. Contacting decision makers only when you need something, that's a very non-strategic move, whereas building relationships in a bidirectional information flow is strategic. And then one thing to keep in mind is that implementing change in a setting of uncertainty, kind of like what we're experiencing right now on COVID-19, that can be non-strategic, not necessarily, but it can be. So one strategic move is just to consider the timing when implementing changes. So let's move on to the first skill, and that's relationship building. And you'll notice quite a bit of time is spent here. That's because it just cannot be underestimated how important this is. So social capital is the most basic and powerful form of influence that we have. Relationships we need to build and nurture with key decision makers. So it's not a one-off. When you need something, you send an email saying this is who I am or schedule a meeting. These are relationships that should be built and nurtured over time. And there's lots of opportunities for relationship building. So it may be stakeholder meetings, maybe volunteer events, educational committees, even just simple email communications. You see something that is of interest to a stakeholder or decision maker in your area, forward it to them just as an FYI. That bidirectional information flow is super important. So as in politics, many people ask decision makers for support, but far fewer show appreciation, and even fewer invest this time to continually nurture these relationships. So it is essential, absolutely essential. So how do you nurture relationships? Well, one, send thank you notes or emails when something is done for you. Forward information on, like I talked about, in terms of topics on mutual interest. Have a follow-up email. When a decision's made and a change is made, send a quick email or give credit during a committee meeting that says, hey, this is the improvement we made. We improved our lung function by X%, or we decreased our overtime by Y%, whatever it is. But give credit to the stakeholders who helped you get the additional resources. So here's some myths that get in the way of relationship building. One are role perceptions. One is all healthcare administrators care about is money profit. All physicians or clinicians are irresponsible with financial resources. These are similar but very different positions. You'll notice clinicians are focused on the health of patients and programs. Healthcare administrators are also focused on the health, but have multiple programs in the entire organization. But these perceptions of the other can lead to really wide cultural gaps in health systems. And, some people believe that this overarching reason for the gap in understanding is just the increased complexity of our healthcare systems. If we think back to what things looked like 50 years ago and today, they're quite different. Here's some tips for building relationships between clinicians and administrators. This one, again, is one of those cannot be overstated, and that is to keep patients at the center of all of your conversations. And then to establish physician-administrator dyads for program leadership. And I mean a real partnership, not just check the meeting, get together annually, but a real partnership. And then, of course, you want to just create opportunities for interaction. So what do we do when disagreements or misunderstandings arise? I think in all relationships, assuming good intent, I can't tell you how many times someone comes into my office, very hot and bothered about something, or it might be myself, and I have to remind myself or the other person to assume good intent. It goes a long way. Meeting the situation with the spirit of curiosity can really help, really seeking understanding of how each of your perspective fits into the whole. And then also recognizing that conflict is not inherently good or bad. Conflict is just a signal, it's an alert to differences. But how we respond to conflict is very, very important. So let's talk a little bit about collaborative conflict. Collaborative conflict is an approach that keeps the challenge itself as the focus rather than the people. So, when you start hearing red flags, it's about, the person doesn't understand, the person doesn't get it, rather than the issue or the challenge itself. So in collaborative conflict, people form to work together to attack the challenge rather than attacking each other. And this approach builds trust. So again, very important, I believe, in all relationships. So some final words on relationship building is that we simply can't overestimate the impact of relationship building. When relationships are multi-directional and have been built with sincerity, they can go a long way. Trust is established. Decision makers will look for reasons to say yes rather than look for reasons to say no. This is critical. That mindset matters. You want your decision makers to be looking for reasons to support your request. All right, let's move into the next set of skills, and that's advocacy. We already know what it means to be an advocate. We're patient advocates. We're familiar with political advocacy. Program advocacy is really combining elements of both patient and political advocacy. Again, patients should remain at the center of all efforts. And as in politics, program advocacy is an iterative process. It's intentional and it takes time, with the caveat that, of course, urgent issues call for urgent responses. So there's 4 main phases of advocacy. You'll see some real similarity here. If you've studied change management, if you've studied quality improvement, you'll see some similarities, and there definitely are. Needs assessment is generally where we start. Planning, implementation, and evaluation. Typically, we spend the most time on implementation, but we should be spending the most time on needs assessment and on planning. And then the area most often forgotten about is the circle back and evaluate how your changes affected. So let's talk briefly about this needs assessment phase. Really, as much time as reasonable under your circumstances should be spent in this phase. So, of course, every issue is different, but as much time as possible should be spent here. You can save time in the long run by having adequate time in this needs assessment and planning phase. So what are the questions we ask ourselves at this phase? We ask about what do we need? How do we know we need it? What data is needed? Where will we get it? And most of us use data to support these positions. We're very familiar with quantitative data, and I do want to talk more about qualitative data, though. So here's some examples of quantitative data. Again, nothing super surprising here. We've got research, QI, even EMR reports. We've got all of our public data. We might have some time process studies. We might have accreditation and regulatory findings. But what I want to focus on is our qualitative data, because we use that less and we use it less effectively. So all of our patient experience feedback is super important. Our informal feedback can be captured as well. Even social media feedback can be captured. Sometimes we can do a day in the life. Maybe we write up a written description of what a day in X life is like. Better yet, an invitation to shadow. Even regulatory or accreditation findings may also be qualitative. So let's talk about the qualitative data and what makes it so important. So, first of all, stories. We should not underestimate the power of a story to influence. Stories are the primary method that we use to communicate, and patient narratives and illness stories, they serve a function, and it's a really important one. They improve visibility. They transform complex issues so they're easier to understand. They make abstract issues feel real to the listener. They can elicit emotional response and also compel social or political action. All right, let's move on to the next phases in the advocacy process. One is the planning phase. So the questions we ask ourselves at this stage is, who do you want to reach and what do you want them to do? How will you get them to do it? And how will you measure success once it's done? In this phase, a really clear call to action is critical. And we want to use data not just to inform our needs assessment, to inform our strategies as well as to how we will do something. We want to clarify our concerns and make sure that we can very clearly and concisely articulate the issues. This is super important as well. We want to talk with stakeholders and decision makers. What I want to emphasize here is we often gravitate to those we know will agree with us. We want to also gravitate and include those who do not agree with you necessarily. This is called a strange bedfellows campaign. So a really good tactic to find out, what are the disagreements and tackle them proactively. We also want to question our own assumptions and bias. In the implementation phase, this is where most people mistakenly spend most of the time. Questions to ask at this stage is, do you need a pilot? Is a phased approach needed? What allies might support implementation and training? And then we get to the evaluation phase. In the evaluation phase, this is the stage most often forgotten or admitted. Very similar to quality improvement, isn't it? And those of you who've been trained in quality improvement know that this, the assess and reassess phase often get omitted. Same thing in advocacy. So in this phase, we evaluate successes, challenges, problems. We identify future or further needs. And sometimes we start the research and planning phase all again. Remember, this is an iterative process. So we make adjustments, may require some compromise. One thing I would also like to emphasize is that incrementalism is a credible strategy. So maybe you start out wanting to make huge changes and you make a tiny incremental change. That counts. This is where you back up, you replan, and you do it again. And it almost always requires multiple cycles before success. So in summary, we had multiple challenges around program development with our CF program at UCSD. Over time, we learned a lot of skills that helped us navigate this. One is that transparency around mistakes is essential for learning. So again, I think we don't share our mistakes often enough, so I hope our mistakes help you. Program development requires a strategic mindset. That strategic mindset is essential, really important. Relationship building is critical to success. I think the two things that are most important to remember is the strategic mindset and relationship building. Advocacy is a key skill for program development. It's an iterative process. Nothing's perfect. Modification and refinement are essential. And really, you need persistence and patience in order to be successful. Thank you very much.